All right, so thank you for coming out to learn a bit about Parkinson's disease today, whether you yourself have it or a family member or friend has it and you just want to learn some information. Hopefully this will help you learn a bit about it. So, first of all, what is Parkinson's disease? Parkinson's disease is what we call a neurodegenerative disorder, and what that means is that it's a chronic condition that affects the function of the brain. In other words, it's a condition that lasts many years and it progresses over the years, and it, like I said, affects the brain. And in Parkinson's disease, the part of the brain that's affected is called the substantia nigra, and here's a picture of the substantia nigra here, and it's called that because you can see these little black areas are affected, and that's the substantia nigra. And over time, those cells, if someone has Parkinson's disease, those cells degenerate, and that's where the neurodegeneration comes in. And this degeneration makes it difficult for the brain to make a chemical that carries a signal called dopamine to be produced. And this dopamine is what we call a neurotransmitter. And that particular neurotransmitter, that signal, helps carry signals from the brain, eventually to our muscles, to move. And so that gives you an idea of what's affected in Parkinson's disease. And like I said before, dopamine transmits these messages from the brain to the rest of the body to create movement and maintain your balance. So if dopamine, this neurotransmitter that you see right here on the slide, is depleted, then the brain won't properly transmit signals from the brain that are needed to initiate movement to the rest of the body. So you'll have slowness of movement and other things that I'll describe later in this talk. And so how many people get Parkinson's disease? What is the epidemiology behind Parkinson's disease? 60,000 people in the United States are diagnosed with Parkinson's disease each year. So 60,000 new cases are diagnosed with individuals are diagnosed with PD, or new cases each year. 10 million people in the world are estimated to have Parkinson's disease, with only 1 million of those individuals living in the United States. And the average age at which someone is diagnosed with Parkinson's disease is 60 years of age, and it's estimated that 4% of diagnosed are diagnosed prior to age 50, and we call those early onset Parkinson's disease. It is known that men do have a higher risk of developing PD in women, and we do see plenty of women who do have Parkinson's disease, though. And some rare cases, roughly 15% of the Parkinson's disease cases that we see in the clinic, have genetic mutations associated with certain genes that run in families. And again, that's a very small portion of cases that we see. Symptoms of Parkinson's disease. Like I mentioned before, some people become slow because they have difficulty moving their muscles because of that lack of dopamine in their brain. People also develop what we call the other cardinal signs of Parkinson's disease. And the 4 cardinal signs that we see in Parkinson's disease are tremor, or shaking of the arms, the legs, chin, or face. It can happen anywhere. Slowness of movement that I mentioned before. Bradykinesia is the medical term for it. This includes slowness of walking and slowness of initiating movements. We also see stiffness or rigidity of the muscles, and we see that when we examine and we turn the arm around, and we see that the muscles are very stiff in the arm and the legs, the neck. And then also, and lastly, postural instability, or in real life we would see, frequent falls, poor balance, things like that. All of these could occur in Parkinson's. So here are some of the other symptoms I mentioned. The stooped posture, as you see here. The low or difficulty to hear voice, we call that in medical terms hypophonia. Smaller handwriting or micrographia, and this is an example of someone's handwriting getting a little bit worse as the years go on. He's saying in 1998, and then 2 years later in the progression of the disease. And sometimes people present initially with micrographia or small handwriting, in fact. Pain, and that's how sometimes the rigidity presents. People don't know, they don't move their arm around on a daily basis. That's something we don't do from day to day, but they might experience some vague neck pain or arm pain, shoulder pain, things like that. And like I mentioned before, the low facial expressions, the reduced facial expressions, we call hypomimia, or reduced facial expressions. Difficulty getting out of a chair because of that postural instability, that propensity to fall backwards into a chair. And difficulty getting out of the chair, like I mentioned, difficulty swinging arms when you're walking. We call that reduced arm swing. And then difficulty swallowing is something that people commonly present with. And just to show you an example of the low facial expression, again, you could see sometimes their mouths are open constantly or quite a bit, and then they have reduced blink rate. They don't blink as much as people without Parkinson's disease, and just some subtle features like that. Sometimes even black out or pass out. The gastrointestinal symptoms I already mentioned. The constipation is very common. Some people develop poor appetite because food isn't moving through their gastrointestinal system like it used to, and some people have weight loss because of that. And then lastly, some patients have what we call urinary incontinence, or difficulty holding their urine, or they have frequency. They go to the bathroom many times throughout the day, and oftentimes a lot through the night. We call that nocturia in medical terms, and what that means is that you get up quite often during the evening and it disrupts your sleep, and you're very tired the next day because you're going to the bathroom a lot overnight. And then lastly, you have urgency, or this sudden urge to go to the bathroom. And other symptoms that don't affect the motor aspects of the body, or motor symptoms, other non-motor symptoms are thinking and memory problems, or difficulty with planning, multitasking, remembering things. So people have difficulty driving sometimes because they can't quite figure out the visual spatial aspect of driving, and also they have difficulty multitasking. Other things are mood symptoms. People feel depressed or sad. Some people feel jittery or anxious for no reason they could really easily identify. Other psychiatric symptoms that individuals with Parkinson's may experience are what we call hallucinations, or seeing things that aren't there. Most commonly, they see things that aren't there, or they could hear things that aren't there, but that's far less common. And they can also feel fatigue or severe tiredness throughout the day, difficulty sleeping or insomnia, or disturbed sleep, and sometimes people have a lot of difficulty sleeping because they have a lot of pain at night, particularly when they're trying to turn and get in and out of bed, and especially if they're going to the bathroom a lot during the evening. It's just a very big bother for them, and they don't get a lot of sleep, and they're just constantly fatigued. And lastly, some people have what we call REM behavior disorder, or RBD, and in that disorder, people act out dreams. Most people without Parkinson's, they are paralyzed in their REM sleep. They don't move. But in Parkinson's disease, people oftentimes act out dreams. They'll swat at flies in their dreams, they'll hit their bed partner, they'll fall out of bed, knock over the lamp, things like that. So complex movements that typically people don't have in that part of sleep. And very commonly, people do have what we call hyposmia, or low smell, reduced or absent sense of smell. And that can happen very early on in the course of the disease, even before people experience symptoms of Parkinson's disease that we are more familiar with, like the tremor and the slowness. People have this reduced sense of smell. And then lastly, drooling, or the fancy medical term is sialorrhea that you might read on the internet. Drooling could occur because people have difficulty swallowing their secretions in Parkinson's. They don't have the same motor mechanisms they used to in their throat to swallow, so oftentimes those secretions accumulate in their mouth and can be very bothersome or embarrassing for individuals with Parkinson's disease. Well, who diagnoses Parkinson's disease? Typically, people initially go to their primary care physician, their internist, and say, well, I haven't been moving well, I saw this thing on television, maybe I have Parkinson's. And if they do have suspicion, they will typically refer you to a neurologist. And a neurologist, that's what I do. It's a doctor who diagnoses and evaluates for disorders of the brain and the nervous system. And then the neurologist could either treat an individual with Parkinson's disease after making the diagnosis on their own, or they could refer them to a movement disorder specialist. And a movement disorder specialist is an individual that is a neurologist, and they specialize in just Parkinson's disease and other related movement disorders. So if there's a suspicion of Parkinson's disease, the neurologist or movement disorder specialist does a variety of things to assess if one truly does have Parkinson's disease before making sure that that's what they're treating with the particular medications that we use. And it's important to state that Parkinson's disease is what we call a clinical diagnosis. And what that means is that Parkinson's disease is diagnosed by physical examination. There's no specific laboratory test or what we call a biomarker to say that someone definitively has Parkinson's disease. We typically go off of just the physical exam. When we evaluate you, we see smaller or slower finger taps or slow movements, rigid muscles, and we put it all together and call it Parkinson's disease. However, if there's any doubt, people could, or neurologists, movement disorder specialists could obtain other scans or medical tests that assess for Parkinson's disease. They could get an MRI or what we call a DAT scan or dopamine transporter scan, and that's what you see here. And we could also get what we call a PET scan or positron emission spectroscopy scan. And these sorts of scans can help us assess if someone truly has Parkinson's disease if we're a little unclear of the diagnosis, because there's other diseases that mimic Parkinson's disease called Parkinson's plus syndromes, and those aren't as responsive to the medications that we use to treat PD, so it's very important to differentiate those sometimes. And then lastly, we could obtain genetic testing if we think it's necessary, as in if someone with Parkinson's disease has many family members, or both their mom and dad and their children, their mom and dad had it and their children may be at risk for Parkinson's disease as well. And I just wanted to point out that the DAT scan that I mentioned here, this is the DAT scan, and that neurotransmitter, that signal that I mentioned before, the dopamine, that is what this looks for. And this is a normal brain or a brain without Parkinson's disease, and you see that it lights up and it's a nice little comma shape right there. And you see the whole thing lit up here on both sides. There's two sides here, the right and the left. And then you see here with someone who has Parkinson's disease, you see you don't see the tail of the comma. You see it's abnormal. So this kind of demonstrates how dopamine is low in the brain in a person with Parkinson's disease. It's a visual of that. So other medications that we use when individuals start to have wearing off of the medication prematurely is called Sinemet-CR, extended release Sinemet. It's the same carbidopa-levodopa, it just lasts a bit longer. And the Rytary is another medication, also includes carbidopa-levodopa, but it includes both extended release as well as immediate release. Carbidopa-levodopa, so someone just takes one pill and you're covered, you have an initial spike of the medication, and some of the medication lasts you throughout the day or many more hours. We have what we call Parcopa, or a Sinemet that can be chewed and put under your tongue and swallowed without water and absorbed much more quickly when someone is very worn off, or they're very rigid and have a lot of tremors. They are very distressed and they need a quick boost, and that's why we take a medication like Parcopa. And again, these are all the same levodopa sort of medication, but with different formulations to do different things and different mechanisms, and last longer or shorter in the bloodstream. And then lastly, we have a gel form of Duopa, and we usually we never go to this right away when we diagnose someone with someone with Parkinson's disease. But Duopa is a sort of medication. It's a gel form of levodopa, again, same sort of medication, but it's absorbed directly into the small intestine, and how it gets into the small intestine is what we call a PEG tube, or just a tube that goes right into the abdomen, and it's absorbed slowly over the course of the day. And again, this is for a patient population that has had Parkinson's for many years, and they have very distressing wearing offs, and we've tried many of these medications before, but nowadays this is an option, and we do that at Columbia University. So some of the side effects that we see with levodopa, and so that means all the medications that I previously mentioned, are nausea, constipation, which you already experience with Parkinson's disease, but this could sometimes make it worse, dizziness upon standing, confusion, and it could cause hallucinations, or the worsening of hallucinations if they already exist in a patient. So those are side effects, some of them more common than others. The nausea is quite common, and we oftentimes tell people to eat food with the levodopa if they're experiencing nausea to help dampen that side effect. Constipation we could treat easily with stool softeners and things like that in Parkinson's disease population. And other things like hallucinations are a little bit harder to combat. When levodopa is given to patients with Parkinson's disease, people could develop involuntary movements called dyskinesias, and I'll show you a video of what that looks like. And these dyskinesias induced by levodopa happen only in patients with Parkinson's disease when they're given levodopa. And they could be described as swaying, writhing, and fidgeting. And another type of medication that patients take in addition to levodopa, or sometimes before they take levodopa, are called dopamine agonists. And these medications directly affect the dopamine receptors that need dopamine in the brain. And they are used to avoid the levodopa-associated side effects like the dyskinesias I just talked about, especially when treating the younger patients, usually before the age of 50 or 60, we would use a dopamine agonist instead of something like levodopa straight away in a younger patient. And this is also taken 2 to 3 times a day. There's some long-acting formulations of these dopamine agonists. Requip, bromocriptine is another one. We have Nupro patches as well, is an injection called apokin or apomorphine. So some of the side effects that we see with dopamine agonists are fatigue, nausea, low blood pressure, hypotension, medical terms, and dizziness, which we do see with the levodopa, and sometimes confusion and leg swelling. Something that we get very worried about as neurologists and movement disorder specialists are what we call impulsivity disorders, or ICDs, and this is described as excessive gambling, hypersexuality, repetitive behaviors, or the medical term for that is punding, excessive eating, or things along those lines. And again, they're called impulse control disorders, or ICDs. And these could happen when you take these medications. And so we always screen for that when a patient's taking them. And if they do have them, they're very hard to combat. So we typically decrease and take the medication off and go over to levodopa or an equivalent. That we typically start if it's at the beginning of this disease, before we even start levodopa or a dopamine agonist, or what we called MAO-B inhibitors, or monoamine oxidase B inhibitors. And these used to be, believe it or not, psychiatric medications, but we use these at very low doses, and these medications like selegiline, or a newer medication called rosagiline or Azilect, and Xadago is another newer medication. We use these before we trial the levodopa and the dopamine agonist. And these are taken usually 2 times a day, usually in the morning and early afternoon. And a side effect is commonly insomnia, and that's why we ask them to take it at like 9 o'clock and noon, or 9 and 1 p.m. to combat that, that common side effect of insomnia. And nausea and headache could occur as well. And another medication that we use in addition to the levodopa, we call them COMT inhibitors, or catechol O-methyltransferase, or COMT inhibitors. And this reduces the rate at which the levodopa is broken down in the bloodstream, in addition to the carbidopa that is already attached to the levodopa and the Sinemet formulation. And the other formulations I previously mentioned. And this is commonly called COMT or entacapone. And side effects include nausea, confusion, low blood pressure, and hallucinations, similar to what you would see with plain old levodopa. Called Amantadine, and this used to be used for many years for actually treatment of flu. But now, neurologists use this for treatment of the dyskinesias that I previously mentioned. It's not an amazing medication that gets rid of dyskinesias, but oftentimes we do use it to try to relieve those symptoms a little bit. And this is often, like I said, given in conjunction with the levodopa-containing medication or other anti-Parkinsonian drugs. And so non-medical treatments are many in Parkinson's disease, and we oftentimes prescribe physical therapy for gait training and helping patients with walking and turning and transfers and things like that. Safety is a major issue in Parkinson's disease, and so physical therapists help doctors with getting the point across of what things you could do to be safe in your home and in the community. And if you need a walker or a cane, they help fit you for that and tell you which assistive device would be most helpful to you. And it's very important if you're having frequent falls or near falls, and if mobility is significantly reduced compared to your pre-PD baseline, And again, if you're having difficulty with turns, maintaining posture, falling backwards, things like that. And like I mentioned before, if you need a cane, walker, another assistive device. Pathologist or speech or language pathologist are very important to help patients with Parkinson's disease. Like I mentioned before, swallowing may be affected in Parkinson's disease, and speech pathologists could help people swallow safely or do different video. They do different images and videos, like you see here, looking into the throat to see if you have difficulty swallowing and target different therapies that you could participate in to help with that, or help you figure out what kind of diet that you need to help you swallow safely without choking or getting what we call aspiration pneumonia. And also another component of speech and language therapy is what we call loud therapy, or helping patients with that hypophonia or that low voice that I previously described. And like I mentioned, that's a major issue in PD, and patients oftentimes have a lot of embarrassment, or they feel awkward in public because people aren't listening to them. They feel like they're too low. And so oftentimes we refer patients to this speech therapist, and they specialize in a type of therapy that's very specific to Parkinson's disease called LSVT, or Lee Silverman voice training. And patients tend to like that a lot because they do that therapy where they could speak louder and be heard in social situations, and they tend to like that quite a bit. Therapy is very important for individuals with Parkinson's disease. It helps patients practice using their hands with hand dexterity tasks, things that require fine motor movements. Oftentimes people have difficulty doing little things like buttoning buttons. That's a very common complaint, that we're putting on cufflinks is for gentlemen. That's a very common thing that people complain about and need help with, and OTs are very helpful in that regard. Driving evaluations are other things that occupational therapists help us out with. A doctor like myself would see someone who might have difficulty driving, either because of visual spatial issues, like I mentioned before, or they have difficulty with the dexterity or the motor aspect of driving. Either way, if we have concerns, we could refer them to an occupational therapist who specializes in these driving evaluations, and they could further assess if there are truly difficulties or they're not. You could go ahead and get your driver's license, no problem. It's not like they report it to the DMV or anything. They're not bound to do that, but it does help us out clinically quite a bit, and it really eases the minds of families as well when they're kind of thinking that and they were wondering about their family member for a while. They really help put that diagnosis on paper, if you will. And then most importantly, exercise, something that you could do at home on your own. Stretching is very important. Aerobic activity is very important in Parkinson's disease. There's actually a research study looking at the importance of Tai Chi and improving outcomes in Parkinson's disease, and we recommend all of these things to our patients. There's actually dancing classes, Dance for PD, here in New York and all the different boroughs, as well as boxing, or Rock City Boxing. And that's all over the country, actually. And patients tend to really like that because it helps them in a social setting with other patients who have PD. So there's a social aspect, but it also helps them with balance and coordination, hand-eye coordination, if you can imagine, with boxing. And again, patients really enjoy that. And a lot of neurologists and movement disorder specialists are able to provide you that information either from a website or a contact of some sort if you're interested. And then something that we don't do right away when we meet a patient who is newly diagnosed with Parkinson's disease, but something we always certainly consider along the course of the disease, is something called deep brain stimulation surgery, DBS. And like I've mentioned before, PD is oftentimes treated with medications, therapy, exercise, non-invasive therapies. But sometimes surgery, this DBS surgery, is oftentimes considered for patients who have that frequent wearing off that I described before. Bothersome dyskinesias, like I mentioned before, some people get dyskinesias and it doesn't bother them one bit. It bothers their families more than them. But some people are very bothered or embarrassed by them. And lastly, people have difficulty tolerating PD medications. We can't go up as high on their levodopa as we could another patient. So when patients have these three things, we oftentimes consider the DBS surgery. And the goal of DBS surgery is to just reduce the amount of PD medications that we need. It doesn't entirely eliminate the need for medications, but it certainly reduces the amount that we need to give a patient to alleviate their PD symptoms.
Sorry, there's a transmitter. Just the DBS, what is that?
I'm sorry?
What does DBS stand for?
Deep brain stimulation.
Okay.
Deep brain stimulation.
Okay.
And this is just a diagram of the DBS, or the deep brain stimulator. You see the part of the brain that it stimulates, a little electrode that goes through the skull and deep into the brain. It doesn't really penetrate the brain tissue per se. It's kind of, well, you can see right here, it kind of gets put into that area. And there's different areas that we target in deep brain stimulation. This part of the brain called the globus pallidus, or the subthalamic nuclei, are the two different areas that we go for in DBS. There's other areas, but I won't get into that. But this is just one example here. And then you see here, there's a battery pack, or the IPG, and this pulse generator has the wire that goes to the brain and stimulates the part of the brain that would be affected in Parkinson's disease, if you will. And it's done in two different stages. The stage one is where the wires are placed using MRI and or electrical recordings or microelectrode recordings to guide the placement of the wire. And then in stage two, the impulse generator battery, the IPG, is placed there. So those are the two stages.
Can you activate that yourself when you feel you need?
It's constantly on.
It's
and
constantly.
yeah, some patients with just essential tremor, that's a totally different disease, they could turn it on and off, but people with Parkinson's disease typically always have it on throughout the day. And you can turn it off with your patient programmer if your doctor programs it to be that way, for things like an MRI. Sometimes that accidentally gets turned off when you go through security at the airport, and we could provide a letter to people who have a DBS, because it's such a issue for a lot of people to not go through TSA, not to go through the magnet because of that. So anything that involves a magnet, we sometimes turn it off for that purpose. So the prognosis of Parkinson's disease is really variable. It varies from person to person. It could be very different from one person, where they slowly progress and they stay in what we call stage one for almost their entire life, and some people progress more rapidly. And so what we recommend is that someone follows very closely with their neurologist every couple, months to, every 6 months to a year. Just make sure that's regular, for you have that continuity of care. Regularly take the medications, the levodopa, on time, because it's very important to take the levodopa as it's prescribed because of that wearing off phenomena. Reducing stress. Stress can make symptoms of PD worse. Maintaining a healthy diet like anyone else, and exercise regularly, like I mentioned before. Parkinson's disease in and of itself is not a fatal disease. However, there are many complications that I've mentioned a bit throughout this talk that could lead to death. For example, aspiration pneumonia, because of the difficulty swallowing. That's why it's so important to treat that and act accordingly. The choking, injuries due to falls. Someone could hit their head when they fall and have a hemorrhage in their brain because of that. So these are all very concerning, and that's why we really emphasize things like therapy, like physical therapy, to help you with turns and prevent falls. And then also the swallowing, like I mentioned a few times before. And so that's the conclusion of the talk. So these are just some resources for patients with Parkinson's disease. I provided the Spanish helpline here, as well as Parkinson Foundation, as well as the APDA, the American Parkinson's Disease Association. There's a lot of helpful diagnosis articles, as well as things for family members and support. And then lastly, we do have a deep brain stimulation support group at Columbia University, and if anyone is interested in that, they could talk to me after the talk.